Welcome to SMA's Southern Medicine podcast. Practicing medicine in the southeastern United States presents unique challenges for healthcare professionals. The South's heavily rural population and limited resources require medical professionals to be more resourceful in their approach to providing quality care. SMA's Southern Medicine podcast addresses these issues by drawing on the experience of healthcare leaders who provide a multi-specialty, interdisciplinary team approach to medicine for the purpose of providing better care for the Southern patient population. Good afternoon. Today we are joined by Dr. Richard Holt, Professor Emeritus and Clinical Professor at the University of Texas Health Science Center at San Antonio. Dr. Holt will discuss both the public health and ethical issues associated with the current novel coronavirus infections. Thank you for speaking with us today, Dr. Holt.
My pleasure. Happy to be here with you.
There has been a lot in the news recently about the coronavirus. Could you please explain the differences between disease outbreak, epidemic, and pandemic in the context of this current novel coronavirus crisis?
Of course, that's an excellent question. Sometimes it's a little difficult to understand what these terms mean in the context of the different types of infectious diseases that we see going on in our society and around the world. A disease outbreak, which is sort of the lowest level of concern for infectious diseases, really is a sudden increase in the occurrences of a disease in a particular time and place. It only takes, according to public health, 4 linked cases of a rare infectious disease to constitute an outbreak. And so examples of this might be the Ebola outbreaks that occur in Africa from time to time, and then the occasional measles outbreaks that we see here in the United States. Usually they're controlled fairly quickly and they don't spread very far, and so the impacts, except for those affected, really are not very great on the country and the people. The epidemic is kicking that type of infection into a little higher orbit. It really is a rapid spread of an infectious disease to a larger number of people in a given population in a short period of time. It's an attack rate of over 15 cases per 100,000 people for 2 consecutive weeks, and we consider that to be an epidemic. So a good example of that might have been the polio epidemics in the 1950s. SARS, the severe acute respiratory syndrome, was considered an epidemic in 2003. I lived as a child through the polio epidemics of the 1950s, and in fact remember very clearly 2 of my friends and classmates coming down with polio, having to be in an iron lung in the hospital, and visiting them during their recovery period. I'll never forget it, and I guess it had some impact on me and my later interest in public health itself. Pandemics are a little bit different. They're really a global disease outbreak. The amount of time for the spread isn't as important as the extent of the outbreak across the world. So now we have the Chinese coronavirus, which is, of course, of real concern to everyone and the topic of this particular podcast. Oftentimes, the pandemics are due to a number of factors, and I'll mention a few right now. Close living quarters, which I think we would all recognize is common in China. Concentrated populations as well. Severity of the disease, the mode of transmission, especially respiratory, but I believe they also feel that this particular coronavirus can be transmitted through fecal samples. Has a short incubation period, and in this particular case, something like 2 to 3 to 14 days, which is not too long, but it's a mild to moderate length of incubation. Other worrisome things are fairly fluid travel by air, land, sea among affected and unaffected populations. Are there viable treatments? Are there preventive measures such as vaccines? And how about the public health response? Is it delayed? Is it immediate? Is it effective? And so forth. So pandemic is really caused by combinations of each of these, and I think we're seeing that in the coronavirus. About at least today, 30,000 people or more have been infected globally in 25 countries, and approaching 700 at least individuals who are have passed away from this particular disease. 11 in the U.S. to date, maybe even more. There is some concern that perhaps a number reported by the Chinese government is underestimated or underreported. We may not know what that particular number is for a long time.
Thank you for providing some context and some definitions and delineations of these terms. What are some of the public health protocols and controls to prevent, identify, limit, and control epidemics and pandemics?
Of course, and that's where we are right now. Fortunately, perhaps with the exception of China, other countries, particularly the U.S. and Europe and other first world countries, have really jump-started their public health protocols. Vaccinations, if they're available for the particular infectious disease, will be an important deterrent. We do have reasonably good influenza vaccinations, but at this point in time, no widely available vaccinations for the coronavirus. I'm sure they're working on it feverishly right now, you might say, and hopefully in a little bit of time there'll be some beta testing on some vaccinations. But right now we don't have that available to us. Public education and healthcare worker education are very important. The public needs to be told the truth. They need to understand the extent, the potential for these infectious diseases, as well as how they can go about their own personal preventive and community preventive measures. We do have to have stockpiles of equipment, medications, the equipment to develop the isolation rooms in larger institutions and medical treatment facilities, as well as stockpiling large amounts of personal protection equipment that will be required by the healthcare providers for the individuals who are sick or under isolation. Early identification of the first cases with isolation of victims is really one of the primary protocols for public health, and has worked so well over a number of centuries. Really, the 4 C's are initiated pretty early, at least in the United States, and those include communication, collaboration, control, and containment. We also have to identify the mode of transmission. In this particular infectious disease, it seems to be spread particularly by respiratory, but as I mentioned before, fecal contamination can also be a cause of it. And I just read this morning that they might have identified the vector, and that could be a scaly anteater, which is apparently some sort of a delicacy in China. I think they always felt it was an animal vector to start off with, but weren't exactly sure what exactly the animal was. So this is under investigation right now. Public health officials do have large-scale protocols, and they've been refined and developed over a long period of time through experience, particularly with screening, isolation, treatment, and confinement as needed for suspects and victims themselves. Personal hygiene is always important. We don't know for sure right now whether hand sanitizer actually works against this particular coronavirus, but it's better than nothing. Good hand washing is vitally important in all settings, from schools to hospitals. The public needs to know the safest and most effective way to seek medical attention if they feel they may have been exposed or have symptoms. Right now, I see information saying if you feel like you might have the coronavirus for some reason being exposed, to go to your primary care doctor or other medical treatment facilities. I think that needs to be refined because I see in my mind's eye people going to a regular clinic or their doctor's office and walking in and then getting an exam room and telling some people, oh, I think I may have coronavirus. And that is really the primary function of the primary care providers, to have some methodology of protecting other patients, their staff themselves, for walk-ins like that. And I think many offices are doing it really quite effectively. Face masks do work. Even the ones you see that have the elastic around the ears provide a little bit of help, but not too much, because droplets can actually go through the filters and can actually moisten the mask, and then the patient can breathe that in. Best ones for general population are really the N95 respirators. In fact, I always keep a box of those in my car and in my doctor bag wherever I go, just in case I come across something like that. Most doctors don't do that, but I'm one who does. And then the proper treatment with antivirals, treatment of the complications, which are usually pulmonary, and support the cardiovascular system, treat the patients with IV fluids in special isolation units. Containment and isolation and all really requires society's involvement and support. And also a limitation of travel across borders. And I think our government right now has been doing a pretty good job of that sort of thing. Right now, we here in San Antonio have received at least one air evacuation of American citizens from the Wuhan province area to be confined at one of our military bases. The public here in San Antonio, when they heard about it, was a little leery, but we know that they're going to be housed in a special area that's going to be fenced off and fence patrolled by U.S. Marshals. So you see the extent of the confinement that is being used right now.
Are there ethical issues involved in the necessity to contain and isolate possible exposed individuals when implementing these public health protocols?
Well, that certainly is part and parcel of what happens in the public health arena for these epidemics and outbreaks and pandemics. Just about any issue that involves patient care can potentially have some ethical dilemmas arise in the process of providing that kind of treatment. I mentioned before the societal acceptance of the isolation, confinement, containment is so important. And honestly, it varies from country to country. For instance, Great Britain has been tuned in to public health issues longer than the U.S. They've gone through some very serious things in the past. The global influenza that killed so many people, the plagues that they have had there. And they have a very robust public health system. I'd say that, in my opinion, Japanese citizens may be more receptive to these sorts of isolation issues than, say, Spanish citizens, simply because their culture is more in tune with accepting that sort of thing. Now, in the U.S., primary ethical principle really is autonomy. And remember, the ethical principles are autonomy, beneficence, non-maleficence, which is do no harm, and then social justice. We really are a very fiercely independent society in the U.S., and we don't like to be told what to do for the most part. And you see that with hurricanes and floods and so forth. There's always a group of people who don't want to leave their homes, even though they've been warned and told. They just won't do it, and that's their right, even though sometimes they will cause first responders to be placed at undue risk trying to save them. So population health and health of the public really needs to prevail in these epidemics and pandemics. The AMA Code of Ethics, Opinion 8.4, entitled Ethical Use of Quarantine and Isolation, is one I'd recommend to the listeners because it does really point out a lot of the issues that are going on. We are guided here in the U.S. pretty much by utilitarian ethics in these particular settings. These are the principles brought forth by Jeremy Bentham and John Stuart Mill and reflected in the phrase, greatest amount of good for the greatest number. And so we as a people, we as a medical profession have to make the most ethical choices of all of the possibilities for the greatest number of individuals. And at times, society must impose its judgment on the individual. And that's why we have U.S. Marshals patrolling the area around the confinement areas here on our Air Force Base to protect the public. Additionally, it really is part of the ethical principle of social justice, that is equal care for those in need, as well as beneficence to do good for individuals as well as the population. Failure of a society to follow these population-based ethics can really cause a problem with faster and increased spread of the disease and make any containment efforts harder. It's sort of like, the horses out of the barn unless you get it in time. There are people from other countries who are trying to get to the U.S., even though they may know that they have been infected, just to get to our better healthcare system here. I guess it's good for them, but it's unfair to all the people that they expose in their travel and once they get to the U.S. So we really have to be very tightly controlling our arrivals and borders and so forth, in my opinion. For those individuals who are being taken care of or in confinement, we still have the ethical duty to protect their personal health information. It is not tell everybody that they have it. Don't give out the names, don't give out where they're being taken care of and that sort of thing. So even though in disasters, sometimes personal health information suffers a bit, in this particular case, I think we're doing a very good job of not letting that information out.
Do physicians have an ethical responsibility to care for patients during outbreaks, epidemics, and pandemics? I know we saw some of this during Hurricane Katrina, and I would be interested in getting your insight with this current situation.
Yes, it is a dilemma, and it's one not only for the healthcare profession, but also for individual healthcare providers. And I'm not using just strictly the term physicians here, because in these sorts of epidemics and pandemics, there is a wide range of individuals who are participating in the care and treatment and so forth of victims and exposed individuals. That would include mid-level providers, hospital nurses, staff, all sorts of people. And so everybody takes part in these things has pretty much an equal risk. And that risk is shared across the whole healthcare industry and not just by physicians. In our training, we learn to take care of individual patients, and that's been the way forever. Population-based medicine is gaining a little ground, but it's not here yet. Only in cases that we're seeing here with these kinds of outbreaks and epidemics and so forth of infectious diseases. It's hard for individual physicians who take care of individual patients to think perhaps in a little broader terms of what their obligations are to society and to the population itself. Some physicians, because of the choice they made on specialties, such as infectious disease, pulmonary medicine, critical care, emergency medicine, all, would be a bit more at risk because they're going to be some of the first line individuals to look after persons who are probably infected with the disease itself. They have also been trained better than many others in how to protect themselves and their staff and other individuals. So they're really important in the scheme of physicians' responsibilities here. Another group of people, perhaps the farther extreme, are those who are actually suiting up and caring for the patients in the reverse airflow isolation units found in medical treatment facilities. They're drawing the blood, they're starting the IVs, they're caring for the patients, they're suctioning these individuals. And so they are at a higher risk, and those are the ones who hopefully have had the extensive training and preparation for these sorts of responsibilities. What about the rest of us, those of us who really aren't in those categories I mentioned? Well, there are a lot of things that we have an obligation to do. One is perhaps to take over caring for the regular patients that these physicians are caring for, but yet are involved in the specialized care of the pandemic victims. Also, somebody has to continue to take care of all the endemic diseases and problems that occur in our population every day. Accidents, falls, non-infectious pneumonia, and so forth. So that's one way that some of us can actually contribute to the effort in our daily practice. Other individuals, other physicians and healthcare providers may have specialized training in facility management, organizing large groups of individuals. We see these capabilities in military leaders and military personnel, but also arranging for supplies and things like that. Just running the machinery of healthcare in these times of need of epidemics and pandemics. Every one of us needs to be able to step forward if necessary, but unfortunately not all of us are actually trained or prepared to do so. When it comes down to it, we have some examples in the past. During the SARS outbreak in 2003, there were hospital units that were stepping up very quickly, and some individuals were not quite ready and hadn't been trained particularly well, also with the Ebola cases that came to the U.S. And they did not know about the personal protective equipment efficacy and how to wear it and so forth, and they got exposed. So they did it, and I admire that they did it, and I'm sorry they got ill, but it's a good example of why we all need to be prepared to step forward if necessary. Now, the AMA opinion of the Code of Ethics 9.067 reads as follows: because of their, in parentheses, our commitment to care for the sick and injured. Individual physicians have an obligation to provide urgent medical care during disasters and epidemics and terrorist events. But the caveat is you should be prepared, and the people who are prepared should lead the way as far as taking care of individuals who are at high risk. I wouldn't necessarily think that a dermatologist or a psychiatrist would need to step up and become an isolation physician and care for the sick people. So there are other ways to contribute. As we saw, and you alluded to it, in Hurricane Katrina aftermath, there were a number of hospitals that were isolated from outside help and had very limited supplies and dwindling supplies. And individuals, physicians who were stuck there, had to make decisions about patient care that often were outside of their scope of practice. We interviewed Dr. Anna Poe for the Southern Medical Journal, just in lessons learned and where this should go as far as enhanced preparation. And I think she was such a great case about the difficulties of preparing physicians to respond to these disasters without having a forethought and knowledge about what might happen if they were stuck in that particular case. Most states now have Good Samaritan laws. Most specialties have some preparation for these, so I think we're in a much better position. And there have been a lot of articles written about how to prepare ethically to make decisions in such disasters and situations such as that. There's always going to be a struggle for healthcare providers, particularly physicians who are team leaders, about how much should they get involved. Because on the one hand, they feel an ethical obligation to care for the patients who are victims of the outbreak, epidemic, or pandemic. On the other hand, they may fall ill, and then what about all of the patients that they could have taken care of over a long period of time in their career? The only guidance is that this is a dilemma, and each physician must make the decision herself and himself on how to respond and what would be the best actions on their part. So thank you very much for this opportunity, and I hope there's been some information that may be helpful to the listener.
You have provided such valuable information to our listeners, and I know personally I learned quite a bit, just more so defining the differences between outbreaks and epidemics and pandemics. And I think sometimes people use these terms interchangeably when that's not necessarily accurate. And also just the ethical issues that are facing healthcare providers during a situation such as this. It's always extremely interesting to learn more about that and how healthcare professionals can and should be involved in crises such as this. So we really do appreciate your taking the time to talk with us today. And the resources you have mentioned will be available on the website. And we thank you again for your time today.
My pleasure. Thank you very much for the opportunity.
Thank you again for joining us. To subscribe to additional SMA podcasts, please visit sma.org/podcasts.